Hello again. Today I'm going to talk about gastrointestinal bleeding or GI bleeding. This is a common problem that gastroenterologists run into, and other doctors who are taking care of the patient run into this as well. So the approach is supposed to be a team approach. One of the most important things, perhaps the most important thing, is to stabilize the patient when they have gastrointestinal bleeding. So if the patient is having acute bleeding and there's instability of the vital signs, then the patient needs to be stabilized. This is usually done in the emergency room department. Patient is given blood products if needed, or IV saline or Ringer's lactate to stabilize the blood pressure and pulse. And then once the patient is stabilized, and there's a period of time recommended before endoscopic procedures are accomplished, and that's generally can be 6 hours or perhaps shorter if necessary. But generally you give patients time to be stabilized before you do endoscopic procedures. In San Antonio, I had the luxury of having anesthesia support. When I first started practicing gastroenterology, and in prior locations, even in civilian practice, we didn't always have anesthesia support, or they weren't always available. And that made the procedure more difficult in some cases. And some cases it went very smoothly and patients responded to the usual sedation that the nurses would give them, which was usually Versed and Demerol, and then later fentanyl instead of Demerol. But there are patients who have been on narcotic medications or sedatives chronically who are resistant to these medications, and so it's always very helpful to have anesthesia perform the sedation while we're doing procedures, and especially if it's a more difficult case and requires a longer period of time to treat and diagnose. So having said that, I will mention that gastrointestinal bleeding can be very straightforward, or it can be a tricky business. Essentially, most of the GI bleeds are from peptic ulcer disease or ulcerations, and again, this may be from aspirin or ibuprofen type drugs or Helicobacter pylori, a combination thereof. Certainly steroids can have an effect and tend to promote ulceration as well. And there's a number of other medications that are associated with the gastrointestinal bleeding. But essentially, we're looking for a bleeding site, and it can be confusing because it's straightforward if the patient is vomiting blood that you have an upper GI source for the blood loss. But the patient is not vomiting blood. Instead, they're passing dark stool or bloody bowel movements. Then it brings up the question of, is there another site in the colon that's bleeding, or further down beyond the stomach and beyond the reach of the upper endoscope? So it can become confusing. So there's been a large series done in massive gastrointestinal bleeding, where most of that bleeding, in the order of 75% or so, was from the colon, and about 17% was from the upper GI tract, and then a small percentage, perhaps 8%, was the area in between, or the small intestine. So these situations can be confusing, and a lot of times in such cases I will elect to look in both areas. Now, in the past, I might have looked in the colon without a prep, because if you have enough blood in the GI tract, it has a tendency to clear out the colon, and you get an idea in the acute setting if there's a bleeding lesion in the colon. And also because diverticular bleeding can be a source of GI bleeding, and it can bleed on and off. And so if you can see a bleeding site like a small vessel in a diverticulum with a blood clot, well, you know that's the bleeding site. And these can change over time. But generally now we have recommendations to go ahead and make sure the patient is prepped if you're going to look in the colon. And I think that's a wise decision, although it may not be as fruitful in terms of what you see. So that's what that then is leading to is that typically what you're going to do is you're going to do an upper endoscopy when the patient is stabilized. And if you don't find an obvious cause or there's a question mark or if there's more than one bleeding site suspected, then you will put the patient through a colon prep. Usually that's go lightly preparation or new lightly. And then what you'll do is you'll look in the colon the next day. And if the patient is not cleaned out and there's a question of what you're looking at, then you may have to continue the prep and do another colonoscopy the next day. So sometimes you'll give the patient a prep and they won't take it all, or they'll take it, but it's still very dark in the colon. You can't see enough to know that you've got a good look at things. And so there can be confusion there. Now, in the acute GI bleeding, where you've got a lot of blood loss and you want to know what's going on as quick as possible, they used to do arteriograms. Nowadays, we're doing CAT scanning with IV contrast or CT angiogram in an effort to see if there is a leak that can be determined with radiologic studies. This can a lot of times reveal the bleeding site, but most of the time it is not helpful. So, but at least it will tell you that the patient has stopped bleeding massively if the CT angiogram is negative. But you have to remember that people bleed on and off, and so there can be confusion there. People can bleed all of a sudden. There'll be blood clots that later show up in the stool, and then there'll be blood clots in the stool after the patient stopped bleeding, but you may think they're still bleeding. And people can bleed on and off, particularly with diverticular bleeding, it seems like. And that can be confusing because you look in there and you see a number of diverticuli, none of them are bleeding at the time you look. And so you're not really sure about the bleeding site. So typically the patient will receive upper endoscopy and colonoscopy, possibly a CT angiogram, looking for a source. If all of that's negative, then a decision has to be made whether to look into the small intestine. Now, there's several ways of looking into the small intestine. As an outpatient, the capsule endoscopy can be helpful. That's where you swallow a capsule camera that takes images, and the physician reviews that with his computer, and the images are transferred to a belt that typically the patient wears. This is a procedure that may or may not be helpful. Sometimes the battery will not last until it gets all the way through the small intestine. Sometimes the patient's stomach will not allow the capsule to pass into the small intestine, and it'll just sit in the stomach. And sometimes the capsule will pass something that you can't quite see what it's looking at, but possibly looks abnormal. It can be difficult to know for sure where the capsule is seeing something, even though the computerized images are supposed to tell you that. They may or may not be indicative of the exact site of where the patient's bleeding. That capsule endoscopy usually is only available as an outpatient, although there's some centers, I suspect, that have it available as an inpatient. It's generally done as an outpatient, and that's how the reimbursement and the payment for the capsule endoscopy is usually done. There are small intestinal scopes that are available in some centers. Most of the time this is done in patients who are stable and many times outpatients. There's a small intestinal scope that several different types that are designed to go all the way through the small intestine. Oftentimes they don't get all the way through the small intestine, and you have to approach the small intestine from the colon side, and that requires a colon prep and another procedure to try to visualize the entire small intestine if you need to do that. So there's that situation as well. And then ultimately some patients, and this would be unusual, would require surgery with small intestinal scope being passed or dithered or telescoped through the small intestine by the surgeon to find that bleeding site. Hopefully that had been previously identified by other imaging and procedures. X-ray procedures, the old way of doing contrast material through the mouth to look at the small intestine or other areas of the GI tract is generally not done. The contrast gets in the way of endoscopic procedures and gets in the way of IV contrast with CT that is used, so they're generally not done. There can be very difficult cases to try to figure out. In the book and the chapter I wrote on GI bleeding, I mentioned two cases. When I was a medical student, there was a young woman who had had abortion with an improvised device sometime after she got pregnant, and then started with GI bleeding. It turned out after her hospital stay that finally the team looked at the history that I obtained and realized that this patient had a connection most likely between the uterus and the colon, or a fistula, and was bleeding from that site, and then surgery corrected the abnormality and the bleeding site. There was another case I mentioned having to do with a Meckel's diverticulum. So there's a congenital abnormality called Meckel's diverticulum where I have an outpouching in the small intestine that sometimes has cells in there that produce acid, and there's an ulceration that can develop in GI bleeding. So this patient, we did the full workup, and there was an abnormality on one occasion seen in the small intestine. Eventually he went to surgery for that abnormality, and I was called in for that as well. And fortunately the surgeon did locate the Meckel's diverticulum, and it was treated surgically, and the patient recovered and did well. There are plenty of cases, in fact many cases, that have associated iron deficiency anemia, implying the patient has been bleeding for a long time. So it's acute on top of chronic blood loss. The patient has a chronic anemia from iron deficiency anemia, unrecognized, undiagnosed, and then on top of that starts bleeding. And so that has to be recognized as well. And so it's important to do some iron studies and look at the iron status before giving transfusion so that you don't confuse the situation there. So I should conclude by saying most patients will have a good result from their evaluation and treatment, and the situation will be corrected. I think with that, I'm going to go ahead and conclude this part of the talk. Thank you.